Dear class, we're going to talk about blood drug. Blood drugs describe drugs that are useful in treating important dysfunction of blood, thrombosis, bleeding, circulation problems, and anemia. Thrombosis, the formation of unwanted clot within a blood vessel, is the most common abnormality of hemostasis. Thrombotic disorder include acute myocardial infarction, deep vein thrombosis, pulmonary embolism, and acute ischemic stroke. These are treated with drugs such as anticoagulants and fibrinolytics. Bleeding disorder involving the failure of homeostasis are less common than thromboembolic diseases. This disorder includes hemophilia, which is treated with transfusion of factor VIII prepared by recombinant DNA techniques, and vitamin K deficiency, which is treated with dietary supplements of the vitamin. Anemias caused by nutritional deficiencies such as the commonly encountered iron deficiency anemia can be treated with either dietary or pharmaceutical supplementation. It is important to distinguish between thrombi and emboli. A clot that adheres to a vessel wall is called thrombus, whereas an intravascular clot that floats in the blood is termed an embolus. Thus, a detached thrombus becomes an embolus. Both thrombi and emboli are dangerous because they may occlude blood vessels and deprive tissue of oxygen and nutrients. Arterial thrombosis most often occurs in medium-sized vessels rendered thrombogenic by surface lesion on endothelial cells caused by atherosclerosis. Arterial thrombosis usually consists of a platelet-rich clot. In contrast, venous thrombosis is triggered by blood stasis or inappropriate activation of a coagulation cascade, commonly as a result of a defect in the normal hemostatic defense mechanisms. Venous thrombosis typically involves a clot that is rich in fibrin, with fewer platelets than are observed with arterial clots. Physical trauma to the vascular system, such as a puncture or cut, initiates a complex series of interactions between platelets, endothelial cells, and the coagulation cascade. This interaction leads to homeostasis or cessation of blood loss from a damaged blood vessel. Platelets are central in this process. Initially, there is vasospasm of the damaged blood vessel to prevent further blood loss. The next step involves formation of platelet fibrin plug at the site of the puncture. Chemical mediators such as prostacyclin and nitric oxide are synthesized by intact endothelial cells and act as inhibitors of platelet aggregation. Prostacyclin act by binding to platelet membrane receptors that are coupled to synthesis of cyclic adenosine monophosphate, an intracellular messenger. Elevated level of intracellular cyclic AMP are associated with a decrease in intracellular calcium. This prevents platelet activation and the subsequent release of platelet aggregation agents. The platelet membrane also contains receptors that can bind thrombin, thromboxanes, and expose collagen. In the intact normal vessel, circulating level of thrombin and thromboxane are low, and the intact endothelium covers the collagen in the subendothelial layers. The corresponding platelet receptors are thus unoccupied and remain inactive. As a result, platelet activation and aggregation are not initiated. However, when occupied, each of these receptor types triggers a series of reactions leading to the release into the circulation of intracellular granule by the platelets. This ultimately stimulates platelet aggregation. When the endothelium is injured, platelets adhere to and virtually cover the exposed collagen of the subendothelium. This triggers a complex series of chemical reactions resulting in platelet activation. Local stimulation of coagulation cascade by tissue factor released from the injured tissue and by mediators on the surface of platelet results in formation of thrombin factor 2A. In turn, thrombin, a serine protease, catalyzes the hydrolysis of fibrinogen to fibrin, which is incorporated into the plug. Subsequent cross-linking of the fibrin strands stabilizes the clot and forms a hemostatic platelet fibrin plug. Receptors on the surface of adhering platelets are activated by collagen of the underlying connective tissue. This causes morphologic changes in platelet and the release of platelet granule containing chemical mediators such as adenosine diphosphate, thromboxane A2, serotonin, platelet activation factor, and thrombin. This signaling molecule bind to receptor in the outer membrane of resting platelets circulating nearby. These receptors function as sensors that are activated by signals sent from the adhering platelets. The previously dormant platelets become activated and start to aggregate. These actions are mediated by several messenger systems that ultimately result in elevated level of calcium and a decreased concentration of cyclic AMP within the platelet. Activation of glycoprotein 2B3A receptor that bind fibrinogen and ultimately regulate platelet-platelet interaction and thrombus formation. Fibrinogen, a soluble plasma glycoprotein, simultaneously binds to glycoprotein 2B and 3A receptor on two separate platelets, resulting in platelet cross-linking and platelet aggregation. This leads to an avalanche of platelet aggregation because each activated platelet can recruit other platelets. Now, platelet aggregation inhibitors described below inhibit cyclooxygenase 1 or block glycoprotein 2B and 3A or ADP receptors, thereby interfering in the signal that promote platelet aggregation. Stimulation of platelet by thrombin, collagen, and ADP result in activation of platelet membrane phospholipases that liberate arachidonic acid from membrane phospholipids. Arachidonic acid is first converted to prostaglandin H2 by COX-1. Prostaglandin H2 is further metabolized to thromboxane A2, which is released into plasma. Thromboxane A2 produced by aggregating platelets further promotes the clumping process that is essential for rapid formation of hemostatic plug. Aspirin inhibits thromboxane A2 synthesis from arachidonic acid in platelet by irreversible acetylation of serine, preventing arachidonate from binding to active site, thus inhibition of COX-1. The lifetime of a nucleate platelet, which is approximately 7 to 10 days. Aspirin inhibits thromboxane A2 synthesis from arachidonic acid in platelet by irreversible acetylation of serine, preventing arachidonate from binding to active site, thus inhibition of COX-1. This shifts the balance of chemical mediator to favor the anti-aggregatory effect of prostacyclin, thereby impeding platelet aggregation. The aspirin-induced suppression of thromboxane A2 synthetase and the resulting suppression of platelet aggregation lasts for the life of the anucleate platelet, which is approximately 7 to 10 days. Ticlopidine, clopidogrel, and prasugrel block platelet aggregation, but by a mechanism different from that of aspirin. These drugs irreversibly inhibit the binding of ADP to its receptor on platelets and thereby inhibit the activation of glycoprotein 2B3A receptor required for platelets to bind to fibrinogen and to each other. Ticlopidine has a FDA black box warning due to the severe hematologic adverse reaction associated with its use. All three drugs can cause prolonged bleeding, for which there is no antidote, but bleeding is more common with prasugrel. Serious adverse effects of ticlopidine include neutropenia and aplastic anemia, requiring frequent blood monitoring, especially during the first 3 months of treatment. Clopidogrel causes few adverse reactions and the incidence of neutropenia is lower. The major side effect of prasugrel is bleeding, which can be fatal. Prasugrel has black box warning for bleeding, stroke, and abrupt discontinuation in patients undergoing percutaneous coronary intervention. Dipyridamole, a coronary vasodilator, is used prophylactically to treat angina pectoris. It is usually given in combination with aspirin or warfarin. Dipyridamole increases intracellular level of cyclic AMP by inhibiting cyclic nucleotide phosphodiesterase, resulting in decreased thromboxane A2 synthesis. It may potentiate the effect of prostacyclin to antagonize platelet stickiness and therefore decrease platelet adhesion to thrombogenic surfaces. The coagulation process that generate thrombin consists of two interrelated pathways, the extrinsic and the intrinsic system. The extrinsic system, which is probably the more important system in vivo, is initiated by activation of clotting factor 7 by tissue factor or thromboplastin. Tissue factor is a lipoprotein that is expressed by activated endothelial cells, activated leukocytes, subendothelial fibroblasts, and subendothelial smooth muscle cell at the site of vascular injury. The intrinsic system is triggered by activation of clotting factor 12 following its contact in vitro with glass or highly charged surfaces. In vivo, this pathway may be initiated by factor 12 contact with charged cell surface containing phospholipids. Endogenously, there are several inhibitors of coagulation factors, including protein C, protein S, antithrombin 3, and tissue factor pathway inhibitor. The mechanism of action of several anticoagulant agents, including heparin and heparin-related products, involves activation of this endogenous inhibitor, primarily antithrombin 3. The anticoagulant drug inhibit either the action of coagulation factor, the thrombin inhibitors such as heparin or heparin-related agent, or interfere with synthesis of coagulation factor, the vitamin K antagonists such as warfarin. Heparin and low molecular weight heparins, enoxaparin. Heparin is an injectable, rapidly acting anticoagulant that is often used acutely to interfere with formation of thrombi. Heparin normally occurs as a macromolecular complex with histamine in mast cell, where its physiologic role is unknown. Heparin is used in prevention of venous thrombus and the treatment of a variety of thrombotic disease such as pulmonary embolism and acute myocardial infarction. The realization that low molecular weight form of heparin can also act as anticoagulant led to the isolation of enoxaparin, the first low molecular weight heparin, less than 6,000 Dalton, available in the United States. The low molecular weight heparin are heterogeneous compound, 1/3 the size of unfractionated heparin, produced by the chemical or enzymatic depolymerization of unfractionated heparin. Because they are free of some of the drawback associated with the polymer, they are replacing the use of heparin in many clinical situations. Heparin has the advantage of speedy onset of action, which is rapidly terminated on suspension of therapy. However, it is being supplanted by low molecular weight heparin such as enoxaparin. Because this agent can be conveniently injected subcutaneously on a patient weight-adjusted basis, have predictable therapeutic effect, and have a more predictable pharmacokinetic profile. Despite early hope of fewer side effects of low molecular weight heparin, complications have proven to be similar to those seen with heparin. bleeding complication, hypersensitivity reaction. Heparin preparation are obtained from porcine sources and therefore may be antigenic. Possible adverse reactions include chill, fever, urticaria, and anaphylactic shock. Thrombocytopenia, this condition in which circulating blood contains an abnormally small number of platelets, is a common abnormality among hospital patients receiving heparin. The coumarin anticoagulant, which include commonly used warfarin and rarely used dicumarol, owe their action to their ability to antagonize cofactor function of vitamin K. The only therapeutically relevant coumarin anticoagulant is warfarin. Initially used as rodenticide, warfarin is now widely used clinically as an oral anticoagulant. With the availability of low molecular weight heparin and platelet aggregate inhibitors, however, use of vitamin K antagonists is decreasing. Several of the protein coagulation factors, including factor 2, 7, 9, 10, require vitamin K as a cofactor for their synthesis by the liver. Unlike heparin, the anticoagulant effect of warfarin are not observed until 8 to 12 hours after drug administration, but peak effect may be delayed for 72 to 96 hours. The anticoagulant effect of warfarin can be overcome by the administration of vitamin K. Warfarin is used to prevent the progression or recurrent acute deep vein thrombosis or pulmonary embolism after initial heparin treatment. It is also used for prevention of venous thromboembolism during orthopedic or gynecologic surgery. Prophylactically, it is used in patients with acute myocardial infarction, prosthetic heart valves, and chronic atrial fibrillation. Warfarin should never be used during pregnancy because it is teratogenic and can cause abortion as well as birth defect. If anticoagulant therapy is needed during pregnancy, heparin or low molecular weight heparin may be administered. Dabigatran is the prodrug of active moiety of dabigatran, which is a direct thrombin inhibitor currently approved for prevention of stroke and systemic embolism in patients with atrial fibrillation. Dabigatran is the first oral anticoagulant in 50 years to be approved after the discovery of warfarin. Dabigatran does not require routine monitoring or INR monitoring and has few drug interactions compared to warfarin. Acute thromboembolic disease in selected patients may be treated by the administration of agents that activate the conversion of plasminogen to plasmin, a serine proteinase that hydrolyzes fibrin and thus dissolves clots. Streptokinase is one of the first such agents to be approved, cause a systemic fibrinolytic state that can lead to bleeding problems. Alteplase acts more locally on the thrombotic fibrin to produce fibrinolysis. Urokinase is produced naturally in human kidneys and directly convert plasminogen into active plasmin. Originally used for treatment of deep vein thrombosis and serious pulmonary embolism, thrombolytic drugs are now being used less frequently for these conditions. Their tendency to cause bleeding has also blunted their use in treating acute myocardial infarction or peripheral arterial thrombosis. However, thrombolytic agents are helpful in restoring catheter and shunt function by lysing clots causing occlusions. Thrombolytic agents are also used to dissolve clots that result in strokes. Alteplase, formerly known as tissue plasminogen activator, is a serine protease, but it rapidly activates plasminogen that is bound to fibrin in a thrombus or a hemostatic plug. Alteplase is approved for treatment of myocardial infarction, massive pulmonary embolism, and acute ischemic stroke. Alteplase seems to be superior to streptokinase in dissolving older clots and ultimately may be approved for other applications. Streptokinase is an extracellular protein purified from culture broth of group C beta hemolytic streptococci. Streptokinase has no enzymatic activity. Instead, it forms an active one-to-one complex with plasminogen. This enzymatically active complex converts uncomplex plasminogen to active enzyme plasmin. In addition to hydrolysis of fibrin plaque, the complex also catalyzes the degradation of fibrinogen as well as clotting factor 5 and 7. Streptokinase is approved for use in acute pulmonary embolism, deep vein thrombosis, acute myocardial infarction, arterial thrombosis, and occluded accessions. Streptokinase is a foreign protein and is antigenic. Rashes, fever, and rarely anaphylaxis occur. Urokinase is produced naturally in the body by the kidneys. Therapeutic urokinase is isolated from human kidney cells and has low antigenicity. Urokinase directly cleaves the arginine-valine bond of plasminogen to yield active plasmin. Urokinase is only approved for lysis of pulmonary emboli. Off-label uses include treatment of acute myocardial infarction, arterial thromboembolism, coronary artery thrombosis, and deep venous thrombosis. Urokinase has a short duration of action and is rapidly cleared by the liver. Bleeding problems may have their origin in naturally occurring pathologic conditions such as hemophilia or as a result of fibrinolytic state that may arise after GI surgery or prostatectomy. The use of anticoagulant may also give rise to hemorrhage. Certain natural proteins and vitamin K as well as synthetic antagonists are effective in controlling this bleeding. For example, hemophilia is a consequence of deficiency in plasma coagulation factor, most frequently factor 8 and 9. Blood transfusion is also an option for treating severe hemorrhage. Aminocaproic acid and tranexamic acid can be controlled by the administration of fibrinolytic state can be controlled by administration of aminocaproic acid and tranexamic acid. Both agents are synthetic, orally active, and excreted in the urine, and they inhibit plasminogen activator. Tranexamic acid is 10 times more potent than aminocaproic acid. A potential side effect is intravascular thrombosis. Protamine sulfate antagonists the anticoagulant effect of heparin. This protein is derived from fish sperm or testes and is high in arginine content, which explains its basicity. The positively charged protamine interact with negatively charged heparin, forming a stable complex without anticoagulant activity. The response of vitamin K is slow, requiring about 24 hours. Thus, if immediate hemostasis is required, fresh frozen plasma should be infused. Anemia is defined as below normal plasma hemoglobin concentration resulting from decreased number of circulating red blood cells or an abnormally low total hemoglobin content per unit of blood volume. Anemia can be caused by chronic blood loss, bone marrow abnormalities, increased hemolysis, infection, malignancy, endocrine deficiency, renal failure, and a number of other disease states. Anemia can be at least temporarily corrected by transfusion of whole blood. A large number of drugs cause toxic effect on blood cell, hemoglobin production, or erythropoietic organs, which in turn may cause anemia. In addition, nutritional anemia are caused by dietary deficiency of substances such as iron, folic, and vitamin B12 that are necessary for normal erythropoiesis. Erythropoietin is a glycoprotein normally made by the kidney that regulates red blood cell proliferation and differentiation in bone marrow. Human erythropoietin produced by recombinant DNA technology is effective in treatment of anemia caused by end-stage renal disease, anemia associated with HIV infection, anemia in some cancer patients. Darbepoetin is a long-acting version of erythropoietin with improvement of its biological activity. Clinical trials have shown that hydroxyurea can relieve the painful clinical course of sickle cell disease. In sickle cell disease, the drug apparently increased fetal hemoglobin level, thus diluting the abnormal hemoglobin S. This process takes several months. Polymerization of hemoglobin S is delayed in the treated patient so that painful crises are not caused by sickle cell blocking capillaries and causing tissue anoxia. Important side effects of hydroxyurea include bone marrow suppression and cutaneous vasculitis. It is important that hydroxyurea is administered under the supervision of a physician experienced in treatment of sickle cell disease. Pentoxifylline is a methylxanthine derivative that has been called a rheologic modifier. It increases the deformability of red blood cells, so it improves erythrocyte flexibility and reduce the viscosity of blood. That's it.